you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want you to let you know that we will address as many as we can in the time we have today. And I welcome and request Professor Dr. Amit Goyal to start this session. Welcome, sir. Over to you.
Good evening, all. So, I thank National Board of Examination for giving me this opportunity to interact with you all. And this is a topic which is very close to my practice, and I really enjoy doing these cases. More importantly, this is one of the area which in last few decades ENT surgeons they have almost taken over the lead, and they are giving excellent results in the treatment of this particular pathology. So CSF rhinorrhea. So we all know that. Yeah. So before we start, the roadmap for today's discussion is history, definition and etiology, pathophysiology, preoperative assessment, reconstruction options, the surgical technique, and special considerations with regards to management of diagnosis as well as management of these cases. Because sometimes the diagnosis is also quite challenging in these cases. So a little bit brief about history. So we all know that CSF rhinorrhea conventionally has been treated by neurosurgeons by open craniotomy approaches, mostly in the beginning, many decades back. So the first case was reported in 17th century. In early 20th century, the first successful repair was done by Dandy. He used the bifrontal craniotomy and facial autograft. Then extracranial approaches, they took over, and then nasoorbital incision was used in 1948 by Dolman. And but the thing was that these approaches were very the morbidity rates were high, the success rates were low, and were quite low, in fact, almost 70% success rate only. And they used external incisions and lot of tissue dissection as well as the brain retraction also. If you go for bifrontal craniotomy, the brain retraction is a big problem which may lead to seizures in few cases. So but anyway, in those times, the endoscopes were not used, so we had only these options, and these were being used. But later on, the endoscopy came into view in 80s and 90s, and Pappy, Rebeck, and Hallberg, they all started using, in a few cases, endoscopes to reach those areas and repair the defect. By definition, CSF rhinorrhea is effusion of cerebrospinal fluid due to a direct communication between CSF containing subarachnoid space and the mucosalized spaces of the nose and paranasal sinuses. So here two things are important. One is that CSF, usually we all know it lies in a closed space surrounding the brain tissue, and the nose and PNS, they are mucosalized or mucosal lined spaces, and which may harbor infections also. So if these there is any defect in these any communication in these spaces, then the CSF will leak through nose, and it may be in the form of a clear fluid, or in cases of trauma it may be blood mixed also. If we talk about etiology, so etiology may be traumatic and non-traumatic. Among traumatic, the accidental cases, they take a huge chunk, and most of the cases are immediate. But yes, these cases may present even 2 to 3 months after the trauma also. Among traumatic, the group of patients may be iatrogenic also, or surgical trauma also, like neurosurgical procedures or rhinologic procedures. In neurosurgical procedures, they usually uh, reconstruct the skull base defect. But if sometimes that reconstruction may fail, or in rhinologic procedures like we do FAS or some other procedure, and accidentally we may breach the intervening bone. So it may lead to CSF rhinorrhea. Non-traumatic cases, they are few, but they may present, and mostly the reasons are elevated intracranial pressure. So either due to a neuroplasm or hydrocephalus, or sometimes benign intracranial hypertension, they may present as CSF leaks. And the classical presentation of a patient of benign intracranial hypertension is a middle-aged obese women. They may present with empty sella syndrome also, and all of us know empty sella syndrome is mostly due to CSF pressure. The pituitary is squeezed to minuscule size, and the cellar space we see it as an empty space filled with CSF. The normal ICP etiologies are congenital anomalies or some neoplasm or some erosive process. Skull-based erosive process may be there, a chronic erosive process in certain diseases which may eventually lead to the CSF leaks, or sometimes no known factor is known to us. We can't find any factor and we label them as idiopathic CSF leaks. So Omaya has classified the same things, but he has given a detailed classification like traumatic, accidental, and immediate delayed. Then surgical, neurosurgical procedures like transsphenoidal hypophyseectomy, frontal craniotomy, other skull-based procedures. Then rhinologic procedures like sinus surgery, septoplasty. If we breach the perpendicular plate of ethmoid, we rock it during surgery rather than a smooth, gentle, true cut removal. We rock it with any instrument, then it may lead to the fracture of the this ethmoid the attachment of this vertical plate of ethmoid, and it may lead to CSF leak. So we should be gentle in those areas. Then other combined skull-based procedures may be there. Then again, as we saw, we discussed elevated intracranial pressure like neoplasm, hydrocephalus, which may be communicating or obstructive, BIH, then anomalies, nasopharyngeal CA, sinonasal tumors, or sinus mucoceles, which gradually might erode the intervening bone, osteomyelitis, or granulomatous inflammatory processes. All these may lead to erosion, chronic erosion of the intervening bone. So now, with regards to pathophysiology in brief, so it forms a jacket of fluid around the brain, and it works as a shock absorber, and brain and spinal cord both. So the CSF is secreted by choroid plexus in the ventricles, the lateral, third, and fourth ventricle. We can see these choroid plexus in these ventricles, and it is then absorbed into dural venous sinuses, and it again comes back to the blood. So the choroid plexus, it secretes and it circulates in the entire subarachnoid space, and then it is absorbed by the arachnoid the villi of these uh, venous sinuses. So that's the normal physiology of CSF. Then there has to be a secretion, fine balance between secretion and absorption to maintain the pressure in a normal range. The total volume is ranging between 90 to 150 ml. Out of this, 20 ml lies in ventricles, 50 ml is intracranial subarachnoid space, and 70 ml in paraspinal subarachnoid space. It is secreted at the rate of 20 ml per hour, and so in 24 hours, roughly 350 to 500 liters per day is actually that's what ml per day. It's not liters per. It's ml per day that is secreted, and it is replaced almost 3 to 5 times every day of its entire volume. The pressure is 4 centimeter of water in infants and about 14 centimeter of water in adults. So when we cough, we sneeze, or we blow our nose, or we strain while defecating, or we lift heavy weights, the intra-abdominal pressure, intrathoracic pressure that rises, that leads to increased blood flow towards our decreased venous return and increased flow towards the brain. It leads to increased CSF pressure also. So that these activities, which actually may precipitate silent leak, or even after surgery, these activities may lead to failure of your surgery also. So these activities we should take care even after surgeries also. So as we have discussed this, there is a pressure gradient. So whenever there is, now we can imagine there is pressure, certain amount, 14 centimeters of water, and outside this nasal cavity, paranasal sinuses, they have air. Whenever there is a defect in the bone, or more importantly, a slight defect in the dura, that might lead to gradual because it's a pulsatile space. There is a due to this brain pulsation, the this space is always under pressure. These pulsations gradually may lead to further erosion, and then this pressure gradient may lead to CSF rhinorrhea. So that pressure gradient is important, and sometimes these silent leaks or maybe some chronic erosive process may be there due to these, especially in benign intracranial hypertension. This chronic pulsation and increased pressure is that's the main pathology behind it, etiology behind it. So the common sites of CSF leak, we know that this our nasal cavity, it is in connection with all the three cranial fossa. So if we talk about anterior part, anterior cranial fossa through frontal sinus or ethmoid roof or this cribriform plate, it may come into the nasal cavity, or middle cranial fossa through sphenoid sinus, it may come to the nasal cavity, or middle, this posterior cranial fossa sometimes, very rarely, this clivus may be, eroded, though it's a very rare pathology, but in case of some neoplasm through clivus, posterior cranial fossa also may come directly to the nasal cavity. But middle and posterior cranial fossa, they are in connection with the middle ear and mastoid ear spaces also. So suppose if any pathology lies there, the CSF will leak into the ear, either middle ear or mastoid cavity, and through Eustachian tube, it will come to the nasopharynx and nasal cavity. So these cases are known as otorhinorrhea, CSF otorhinorrhea. So whenever we encounter a case of CSF leak in which we don't find any explainable cause for it, we should always look and examine and maybe investigate these ear pathologies also. So all the three cranial fossa, they may present as CSF rhinorrhea or CSF otorhinorrhea in cases of middle and posterior cranial fossa. Now, there is a clear fluid coming from the nose, and we all know that allergy also leads to rhinorrhea. In sinusitis also there is rhinorrhea. The lacrimation also through nasolacrimal duct, there is a secretion coming into the nose. So how to differentiate between these two, whether it's a case of CSF, the fluid coming out is CSF or it's a routine nasal secretion. So in case of CSF leak, we will have some history of some surgery or head injury or maybe tumor, but sometimes there is no obvious history is present. Still, we have to have some high index of suspicion for these cases. Then nasal secretions, there will be history more related to your allergic symptoms like sneezing, nasal stuffiness, itching in the nose, or maybe lacrimation. Flow of discharge, usually the CSF leak comes in the form of few drops or a stream of fluid, which comes normally when we bend forward or we strain. While in allergic nasal secretions, it's a continuous, there is no effect of bending down or straining, and it can be sniffed back. So whenever there is a discharge coming through the nose and somebody can sniff it back, it's more likely an allergic mucin. And if there is a bending forward effect or straining effect and the discharge cannot be sniffed back, it is CSF more likely. Then in CSF is thin, watery, and clear, while the nasal secretion, that is some mucus type consistency, is slimy, or sometimes clear fluid, tears also come. But tears, then this taste, CSF fluid, normally it's due to presence of sugar, slight sweetish taste is there, while these nasal secretions, they are a bit salty in taste. And beta-2 transferrin, it shows positive on CSF fluid and it's absent on nasal secretions. So it's immunophoresis, the electrophoresis test. So whenever there is a watery discharge and bending forward, history of nasal obstruction or trauma, we should suspect it. Then if there is a watery discharge with the patient is not able to sniff back, history of trauma or vertigo is there with related to ear, or headache, nausea, vomiting, and visual abnormalities, which suggest increased intracranial pressure. Or sometimes the patient directly presents with a complication due to leak, meningitis. The patient may come to you with a history of first-time meningitis or maybe recurrent meningitis with neck stiffness, vomiting, and seizures. Then you may get a call from pediatrics department or medicine department or neurology department that this patient is having recurrent meningitis. You explore and you find there is a defect in the skull base. So sometimes patient does not have a clear-cut related history, but they may present directly with complication also. So you should always have a high index of suspicion whenever you are managing or evaluating these cases. So a patient has come to you, you have a strong suspicion. Now you have to, define whether it is again a CSF or not. One is reservoir sign, because the sinus cavities, they are big, large cavities, especially sphenoid sinus, and the fluid is collected inside. So whenever patient bend forward, there is fluid. Then again, patient after some time again he bends forward. Again there is a stream of fluid. So that's a reservoir sign, because the fluid is collected inside the sinuses, and whenever he bends forward, the fluid comes. Then there is double target sign or halo sign, what we call. So in cases of traumatic CSF, where there is a blood coming through the nose, and you don't know whether this is a pure blood or it contains CSF also. So you take a piece of filter paper and put a drop on this. So what will happen? The CSF will seep out. It will spread on the paper, while the blood will be clotted, and it will be lying mostly in the center. So that will give like a peripheral light halo with the central drop of blood. That's known as halo sign. So that's the diagnostic test for traumatic CSF leak, or maybe in cases where during surgery also you may try this. But during surgery, one problem is that we use a lot of saline sometimes, so that may give rise to a little bit, uh, false reflex. So during surgery, if you want to diagnose whether the patient might be having suspected CSF, that there are certain when we will talk about surgeries, we'll talk about that, how to diagnose CSF leak during surgery. Another is handkerchief test. So whatever discharge is coming from the nose, that is blown on a handkerchief, and it's allowed to dry. So if the discharge is CSF, then the handkerchief will not stiffen, because it's just a clear fluid. If handkerchief is stiffened, because then it is more likely to be nasal secretions, because it contains mucin, which will make it a bit stiff on drying. So again, Valsalva or any other maneuver in which the intrathoracic or intracranial, this intra-abdominal pressure rises, which leads to rise in intracranial pressure, the discharge, it increases on these maneuvers, or maybe on strenuous activity, the discharge increases. That is again another sign of possibility of CSF leak. While in cases of nasal secretions, that there will be no effect of any strenuous activity or increased pressures. So when we do preoperative workup, we have talked about history. We have talked about confirming the leak, whether this is CSF or not. And sometimes in cases where you have doubt, you can go for beta-2 transferrin test, or when you send this thing for biochemical examination, there will be raised glucose in the fluid. That will be indicative of it being CSF. While in blood serum or nasal secretions, well, in this nasal secretions, the sugar is low. In CSF, the sugar is high, and we need to go for. We might need to sometimes in doubtful cases to go for these electrophoresis tests like beta-2 transferrin or beta trace protein. Diagnostic nasal endoscopy is mandatory in all these cases, but we may not necessarily be able to see the leak every time. Now we have to localize the defect, which area of the skull base exactly is the defect, and we have to target. So for that, we have invasive and non-invasive modalities. So one is biochemical, as we have already spoken about, beta-2 transferrin, beta trace protein, and glucose testing. Then investigations, radiological, there can be non-invasive and invasive. Non-invasive investigations, the most important is HRCT, that is high resolution CT scan of paranasal sinuses. High resolution means it's 1 mm or less than 1 mm thickness of slice thickness, and they give a very detailed bony anatomy. But whenever you advise any CT scan, two things you need to keep in your mind very clearly. One is there may be a false positive, diagnosis due to the volume averaging. You might see a small defect while there is actually no defect due to volume averaging of sequences, this data. Another is, especially if you are evaluating a pediatric patient, a large areas of skull base in pediatric patients, they are actually, still cartilaginous. So in those patients, the CT scan may give you a very misleading picture of defects. So there you have to be carefully interpret the CT scan. Another which is actually which we might say for the diagnosis, not for the operative purpose. For surgery, we definitely need an HRCT, but for diagnosis, confirmation of CSF leak, MR, this MR cysternography, it's not MI cysternography, sorry for this typo, graphical error. It's MR cysternography. It's investigation of choice. It is a non-contrast cysternography, T2 weighted images where the CSF is seen bright on MRI, and we can actually trace it coming from the CSF space down to the nose, the paranasal sinuses. The invasive modalities, they are very rarely used, and CT cysternography where we inject intrathecal metrizamide and we take, we put the patient in 10-degree head low position for a few minutes so that this entire contrast is spread throughout the subarachnoid space, and then we take an HRCT. There we can see a clear-cut, contrast leaking out from intracranial cavity through nose through a defect. There is another intrathecal fluorescein with blue filter endoscopy. Now that is also because a lot of morbidity and complications are associated sometimes. So this intrathecal fluorescein is largely abundant, and but sometimes in difficult cases, operatively we might need to use it. So when we intrathecally give fluorescein and when we see with the blue filter, we do a nasal endoscopy, the CSF will be seen green color, right? So like I have said, the CT images, we can see there is some defect with prolapse or a clear-cut defect, bony defect. But to whether it is CSF or not, these MR images are more useful where we can see this meningocele popping out of the intracranial cavity into this ethmoid sinuses, or some CSF leak through a small defect coming out. So this white is actually CSF. We can see it all around. The CSF is there and it's actually coming out. So it's a very good investigation. But for this investigation to be positive, the leak has to be active at that time. So sometimes if it is not informative, we might ask patient to, do some Valsalva or something, and then we may repeat it if we are not able to see the leak. But for bony defect, certainly this CT scan is a better modality. So we need actually both MRI for diagnosis and bony for surgical planning, CT scan for surgical planning. Again, CT cysternography, just to mention, we can see this contrast being seen in this, and it is coming in the nose through a defect, and we can actually trace the entire contrast area. But this is also very rarely required nowadays. Intrathecal fluorescein, as I have said, it's an invasive procedure, and many people have used radioactive substances also. Intrathecally, they used to inject radioactive substances. They used to keep the gamma camera near the nasal cavity or in the nasal cavity, and they used to catch the radioactivity. But that's abundant actually. Intrathecal fluorescein, if you use, it's 0.25 to 0.5 ml. You inject it intrathecal space, keep the patient 10-degree down for some time, and then when you do with blue filter, you do endoscopy, you will see this green color fluid. That will be confirmatory of presence of CSF in the nasal cavity. And sometimes this, this is fluorescent without intrathecal fluorescent, just in the locally also we can just paint the area and we may sometimes see the CSF doing washing out of it. But that's another sort of thing when we don't inject it intrathecally during the surgery. We just paint the area with this fluorescein. We use blue filter endoscopy. We see the entire area green, and through the defect, if any water is coming down, then it will wash that green color. So that washing sign is also important. And during surgery also, if you are doing FAS and you see that wash sign, that blood is being washed away with the fluid coming from, with the water coming from above, then it might be a sign of CSF leak intraoperatively. Okay, so now the treatment that's we have diagnosed is the case of CSF leak. We know the defect. Now, how to treat this entity? So early cases of post-traumatic CSF leaks, because post-traumatic CSF leak may be, self-healing in 1 or 2 weeks time. Spontaneous healing is no, the rates are very high. So they can be managed conservatively. If it's a small defect, we know. So just bed rest, avoidance of any strain, nose blowing, sneezing, stool softeners to avoid any pressure, the strain during defecation, elevation of head of bed to decrease the intracranial pressure. All these things may help, plus minus prophylactic antibiotics. and plus minus lumbar drainage. Lumbar drainage don't have a very, it's the evidence is plus minus, but still few people they prefer to use it. So early cases of post-traumatic CSF leaks can be managed conservatively, but not all the cases. Surgical repair is required in many of the cases. The conventional approach has been bifinural craniotomy by bicornual incision. Apart from that, other external approaches, osteoplastic flap, transseptal approach, sublabial, external ethmoidectomy, for to approach these areas, they have been used. But nowadays, most of the cases we can use endoscopically, or sometimes with this Lynch-Haworth incision we need to give for suppose there is positive table of frontal is defect is there, then we may use the Lynch-Haworth incision sometimes. So the conventional is bicornual incision. Along with this, we remove this bone. We before removing this bone, we have to raise a pericranial flap. Let the flap be attached here. Elevate the pericranial flap, which is a thick periosteum, from here, then remove the bone. And the defect will be, if you look from above, you have retracted the frontal lobes. Here is the, you can, this bone is there and you have gone between the bone and dura. You will be able to see the defect here. Then that pericranial flap from which is attached here, you can make it lie down here and you can just deposit the dura. You can just let it be covered by the dura and the brain above. So that will heal. So that has been the conventional approach. Now, most of the leaks from anterior canal fossa and sphenoid sinus can be managed endoscopically. The key principles, surgical principles, are identify the defect site, because that is very much important. There is no role of blind carpet repair. You have to identify the defect site. Otherwise, the chances of failure are very high. You have to prepare the defect size. Preparation of defect size means when there is a defect, the dura is dehiscent, bone is dehiscent. So you have to remove entire mucosa surrounding the defect from the nasal side, because on mucosa nothing will stick. So you have to make the bone bare surrounding the defect, number one. Number two, you have to elevate the dura all around the defect inside of the defect. So outside of the defect, in the nasal side, you remove mucosa, all mucosa surrounding the defect. Inside the defect, bony defect, you elevate the dura so that there is some space between dura and that bony edges. The repair becomes more promising. Then reduce the meningoencephalo seal by either bipolar or coblation. Mucosa within 5 mm of skull base defect should be removed, minimum 5 mm. The middle and superior turbinate may or may not be removed depending on the need. The facial graft, mostly we use this from thigh or maybe from abdomen. Sometimes you can take the fat and fascia. The mucosal graft should not be placed intracranially, because if you mucosalization has to occur on the nasal side, not on the intracranial side. So intracranially you use fascia lata or fat, and mucosa you use on the nasal side only. If bony defect is quite large, then sometimes cartilage might be needed. And intracranial pressure you have to keep in control after the defect. So the bath plug technique, this is the most commonly used technique for small defects. So as we know, what is bath plug? You must have seen the bathtubs. There is a hole and there is a cover over that hole. So when you fill water in the bathtub, due to pressure of that water, the cover of that hole that more snugly fits and seals the hole. The same concept is being used here. So that is bath plug technique. So we put this fat inside this defect, a big amount of fat, and then when this dura and brain matter that sits over this fat, it completely seals this defect. So due to the pressure of intracranial pressure, due to the pressure of dura and brain, this seals it further more tightly. So to do this, we just delineate the defect, remove the mucosa all around, and we take a suture in such a way that when we pull this particular thread Finally, the entire thread will come out. This knot will be loose, opened up, and this entire thread will be out, leaving behind the fat only. So like this, we push the entire thing inside and then we pull the thread. Sometimes we might use certain instrument also to pull the thread so that the fat doesn't come. And this thread is out and this fat lies mostly intracranially and a little bit this inside the on the nasal side. So this seals the defect completely. For smaller defect, it works perfectly fine. So this is a fat plug or bath plug technique. Then overlay technique means when the dura is adherent to the defect and you cannot elevate the dura. So you put the graft on the nasal side, on this side. But if you are able to elevate the dura, then you put the graft between dura and bone. So that, and then another something outside the bone on the nasal side. So, so this is an overlay, means you are putting the graft outside the defect on the nasal side. And this is an underlay where you are putting the graft between bone and dura inside the bony defect. So like different sites may be there. Sometimes it's this lateral lamella of the cribriform plate may be defect, or if you are able to see this Stenberg canal or what you call congenital dehiscence in the lateral wall of sphenoid due to the persistence of this craniopharyngeal canal, that is Stenberg canal defect may be there, or meningocele or meningoencephalocele may be there at any of the place. Then if no active leak, simple mucosal graft should be fine. But if there is low flow leak, then multi-layer closure may be required. And if there is high flow leak, then definitely multi-layer closure along with the vascular tissue flap or maybe synthetic dural placement, that is the key. So when it's a high flow leak, it's always better to use a vascular tissue flap because the chances of necrosis and this failure are less with that. Surgical sealant may be used in any of these cases. Okay. So autologous graft, the benefits are they are free of biological hazards and they are able to facilitate fibroblastic migration and connective tissue deposition and they are good and cost effective things. And autologous, we can have free grafts as well as vascularized flaps. While these dural replacements, they are usually very costly. So free graft, they are detached from the donor side, transferred and implanted. They lack vascularization, but they may be used as overlay technique as a single layer or multi-layer technique, means a layer inside the bone, a layer outside the bone. So this is just an example of free graft. We elevate and it is like this. Overlay technique, small, just put here and repair it. Now we have to take care of a couple of things. This olfactory pores make the dura fragile. So if we try to elevate, the dura here, it's already very thin bone and very fragile dura. So over small olfactory groove defects may work well with, simple overlay technique graft. Then fascia lata, temporalis fascia, these are the different graft materials which we can use. Free graft, mucopericordial or, mucoperiosteum, then cartilage if we need to take, we can take from septum, nasal septum, concha or tragus, or nasal septal bone or turbinates bone we can take, fat we can harvest. Now heterologous materials like bovine or human lyophilized dura, synthetic materials are there, Gore-Tex patches or porous polyethylene implants or bone substitute materials are there, and dural replacement patches, they do come, but they are very costly. The different materials are available. Vascularized flap, the most important vascularized flap is, posterior septal artery based nasoseptal flap. This is known as Haddad flap. We will see in some time. And other than that, we can have pedicled inferior turbinate or middle turbinate flaps. We can have bipedicled anterior septal or anterior inferior turbinate flap. Extranasal flap, pericranial flap, which I have already described. Then temporoparietal fascia flap, we can take a flap here and through the, inferior this fossa and above we can take it into the nasal cavity. We can create a tunnel there. We can take it into the nasal cavity and we can just make it lie down here. This pericranial flap, sometimes it is being lifted from here. A window is made here, and from here we can pull the entire this temporal parietal fascia flap, which is attached here, inside the nasal cavity, and we can use that as an overlay graft also, not always underlay. Palatal graft or this different more other flaps are there, but they are relatively much rarely used. I was talking about Hada's this Bessa gateway flap. It's a vascularized palatal flap which is based on the nasal posterior nasal on the posterior septal artery. We all know that through spinopalatin artery, it exits through spinopalatin foramen. After that, it divides into two branches. One is anterior branch, which runs over the inferior turbinate, and one is posterior septal branch. So this posterior septal branch, it goes between the sphenoid ostium and the choana, just in between. It comes on the septum and it supplies. So what we take, the landmarks for this graft is just inferior border of this. One is the just above the choana. We make an incision and take it down on the septum, and just below the sphenoid ostium, we take an incision and we take it above. So we take both the incisions anteriorly and we, make them. We join them anteriorly. Then this entire mucoperiosteum can be elevated till here, lateral most part, along with this artery in that. And we can even extend this incision to take the floor mucosa also. So this is a very robust and large areas can be, taken care by that. So we can see that how much big areas of this mucosa we can take. When we take this superior incision superiorly, we have to see that we take it further superior only at the level of anterior end of middle turbinate, not behind and not posterior to that, because that is an area of olfactory epithelium. So we take it anterior, and then we elevate at the level of middle turbinate anterior end. So that this olfactory thing is spared. So it's a very, very robust flap with a very high success rate. So a few cases we will discuss, and then we'll end this discussion. It's a female patient which came with intermittent watery nasal discharge and headache for 10 years. There was a history of road traffic accident 10 years back. And after all the investigation, there was a 9 mm defect in right cribriform plate and herniation of gyrus rectus into the nasal cavity. So if we see that this is actually this is the turbinate, and this is behind the turbinate we can see this herniated meningoencephalous seal. So we prepare it, and then we go behind the turbinate and we start using coblation at the where it is actually just at the neck of this mass, this herniation. So gradually we are taking it down with this. We have taken it down, and now we can see the defect. It is coming in view. This is actually the defect with herniated brain tissue. So we are using bipolar here to stop the bleeding and to this prepare the surrounding of this. What is important, I was telling you that this is, we can see the pulsations. If you can notice the pulsations here, you can see the pulsations of this and the margins of the defect, and all around the defect we have to denude the mucosa should be denuded. That's very, very important when we are repairing these. So we are preparing the bed, and after that we have put the fat intradurally. We put the fat. Then this is the inlay fasciolata, and after that this is overlay fascia. So it's a multi-layered repair with the use of tissue sealant. Then we pack it with we support it with the gel foam and Surgicel, and then we put the Merocell pack after that to support entire thing. Then there is another 36-year-old male who came to us with watery discharge from right. It's a very interesting case. He had history of type 2 diabetes, but there was no leak on DNA. But certainly the beta-2 transferrin was positive, but the most importantly, prolactin was more than 200 nanogram per ml. So we can see it's a case of prolactinoma, giant prolactinoma coming into the sphenoid sinus, and there was a defect in the middle cranial fossa coming into the sphenoid sinus. through that defect, this leak was there. So now to manage this case, we put the patient on conservative management by cabergoline first. We let this entire prolactinoma shrink so that the defect is more clearly seen, and then we repaired the defect. So it was a successful defect, but the key decision was that okay, we put the patient with the guarded risk of meningitis. We put the patient on this cabergoline, and it actually caused that since the tumor shrunk, the defect became more apparent and more CSF leak was there. Another case, it's again a case of spontaneous watery discharge, a male patient, and we can see there is this defect in the Stenberg canal, and this case was operated with the use of nasoseptal flap, a dart flap, which I have discussed. So this is the inferior incision I am taking with the cautery. This is the anterior joint I have already joined. The superior portion has already also been given, and I am lifting the flap. So when we lift the flap, we take it till lateral, entire till posterior part, then anterior face of sphenoid end till lateral part, this till the area of sphenopalatine artery, and we park it in the nasopharynx. So after lifting of this flap, see we have parked this flap. Then we have started drilling. It's a transpterygoid approach. So we have started going laterally in the lateral recess of sphenoid sinus. This defect was there. We can see the defect here, and it's on a different angulation. We can see the pulsations and margins also. So then the defect was repaired here. So another case, 1-year-old male, he presented to us with the water discharge from bilateral nasal cavity. He is a small kid and multiple episodes of high-grade fever. Now, initial impression was CSF rhinorrhoea with recurrent meningitis, but HR, CT, PNS, there was no obvious defect. But the defect was in the patient was actually this cochlear malformation with absent cribriform plate in the left internal auditory canal. So through the left internal auditory canal, through cochlea, the CSF was coming into the this middle ear cavity, then through uterine tube it was coming to the nasal cavity. So this patient was managed with left radical mastoidectomy with CSF leak repair and right-sided cochlear implantation, because on other side also there was no leak, but cochlear anomaly was present. So he was a bilateral profound case. So not all the CSF rhinorrhoea are actually CSF rhinorrhoea. The pathology might be there in the ear also. So this is just the post-operative care and follow-up. We have to give IV antibiotics, oral diuretics. Now, one important lesson: when you are repairing a defect during on table, if you are not identifying the defect, you may ask your anesthetist to perform Valsalva. They can increase the intracranial pressure, and that may make the defect obvious. When you are repairing it, you ask anesthetist to give mannitol so that the brain shrinks and you find a bit more space between brain and dura or dura and bone to work. It becomes a bit easier to work in those areas, to put the graft in those areas. After the surgery, in post-op period, you never give any mannitol because you want the brain and dura to snugly fit on the repair. So you don't want to shrink the brain. You just give diuretics so that the CSF amount is less. CSF amount should be less, but the brain should not be shrunk. That is the concept. Then you give stool softeners, keep the head end elevated, avoid straining. Lumbar drain in high flow leaks, it may make sense, but not all the CSF repairs, they require lumbar drains. There have been enough literature available nowadays, and the complication rates are within acceptable range with endoscopic that leak, septal perforation, donor site complication, prolonged crusting, all these may be there. And it's a level 4 evidence, multi-layer free grafts and synthetic materials, low flow leaks and high flow leaks, pedicle vascular flap. But that's what is a usual practice nowadays. The advantages of endoscopic repair are actually minimum disruption of growth center. Number one, no brain retraction. That's the biggest advantage actually. Preservation of sinonasal physiology, faster recovery, greater acceptance, good cosmesis, and higher success rates. So with that all, my presentation is over, and we can go with the with answering the questions. I think I'll stop sharing my screen and then we can go for the answers, question answers.
Thank you, Dr. Amit. Good evening.
Good evening, ma'am. Good evening. So you were there. I was just
I had joined. I was able to join today.
yeah,
So
thank you.
I must congratulate you. That was a really, really excellent presentation, and with such good videos and the diagrammatic representation, sites of leak, and the radiology. Thank you so much.
Thank you, ma'am. That
And
was
I think
all
you have a
my.
lot of questions lined up by Dr. Yuvraj. He
Okay.
wants to know everything about the technique, a little bit about the doses of the medicines, and so maybe you just go through the chat and
Ma'am, I can see only two questions in the chat. Acetazolamide and phenobarbital, how long to give? Phenobarbital we don't use in all patients. Acetazolamide, usually I prefer minimum 3 weeks time, sometimes till 6 weeks if it's a high flow leak. And vaccination, I don't go for any vaccination in cases of CSF leaks. They are routine cases, means we take them as a routine working patients. Because the meningitis also, not all the patients, they do have meningitis. So role of prophylactic antibiotics is also debatable. We don't practice role of these prophylactic antibiotics also. So that's what we usually practice. But ma'am, I can't see any other more questions.
so he has 3, 4 questions. One is he wants you to explain the bath plug technique once again. He has
Okay.
asked for any role of caffeine and Duragen
So
and
yeah, ma'am,
dose
please.
of cabergoline, reverse Hadad flap.
So ma'am, yeah, any other thing, ma'am? I'll just note down.
Just let me go through this. And what drill that you use, the size of burr. If the defect is found, is it mandatory to use mannitol? What would be your choice of diuretics, the dose, frequency, duration? I think you won't be able to answer all the
I won't be,
questions.
ma'am. Also, I won't be, but maybe you tell me, means one by one, maybe we can take. So I'll be just quick to for the thing.
So
Uh,
bath plug technique, I think that was quite explanatory. Maybe you take the
yeah,
medications one, the
yeah.
role of caffeine um, in cases of CSF leak with headache. Prophylactic, do you advise caffeine prophylactically or therapeutic? And if you
No,
do,
ma'am.
then what would be the dose and duration?
No, ma'am. Caffeine, I have never used for this, any prophylactic or therapeutic. And cabergoline only in cases of prolactinoma. The dose I don't remember because it's not a very frequently used drug. But we
Yeah, yeah,
had only one patient, so and that also was managed by endocrinologist, by the way, for that
yes.
particular part. So we took the patient after the tumor shrunk and the defect was more obvious. And with regards to this
If septal cartilage is not available, would have you ever used Duragen?
Ma'am, Duragen, I have not used, but Duragen, the main key point with Duragen are two folds. One thing is the area should be entirely infection free. The Duragen actually it leads to intense, fibrotic reaction in the nearby areas. So there
Okay.
should be no evidence of meningitis at all, and the area should be relatively much infection free. So it induces fibrosis, and then this layer comes. So that's how it is used. It's quite costly, but it's a very viable material. And recently, I came across one paper where they used relatively hard material, and they say that it's better than routinely available Duragen, but that's only one center's experience. That I just forgot the name, FT, something like that. So it's a
Okay.
relatively hard material, absorbable material they use.
Okay.
So,
Okay.
but it acts by fibrosis. So infection should not be there at all. That's one good one thing we have to take care. And the other thing was,
Uh, once you find a defect, do you always put the patient on mannitol?
no, ma'am. This mannitol, yes, mannitol, yes. After I find the defect, I ask them for mannitol because it makes your work much easier. That's a routine practice for me. And in post-operative period, no mannitol or no glycerol. It's only Diamox. That's what I.
Okay. And do you catheterize the patient?
Ma'am, we catheterize intraoperatively. Post-operatively, we remove the catheter. The simple
Yeah.
reason being the patient is bedridden, but catheter has a much more chances of urethral stricture and this infection. So we don't require catheter. Patient is conscious and he can always ask somebody to help him for that. So catheter is post-operatively no, during surgery only.
Okay. And if you put a lumbar drain,
Yes,
then
ma'am.
when do you remove it?
Ma'am, lumbar
And,
drain, if at all, the average time is 3 days.
when would you put the lumbar drain? Not in
Ma'am, in
all
high
cases,
flow,
but
not all cases, ma'am. In high flow leaks.
high flow leaks.
Yes,
Okay.
ma'am. During surgery, you
So,
get to know. And one more important thing is that on table, after I
yes.
repair, I ask the anesthetist to again do a Valsalva. And
Okay.
there should be no leak after the repair on table. Then only you
Yeah.
can expect success. If there is leak on table, then more chances that post-operatively it will fail.
Yeah. Yeah. So it has to be a snugly fitting,
Snugly fitting repair.
multi-layered repair.
Yes, ma'am. Yes.
Okay. Post-operatively, would you advise a nasal wash? Would you start nasal wash? Do you
Ma'am,
start alkaline douching?
ma'am,
Do
I
you-
remove the pack after 5 days,
Okay.
Merocel, and from 6th day onwards, I start that saline sprays. And
Saline
maybe
spray.
after, yeah, and maybe after 2-3 more days, the passive douching you can start, not the active douching, not that
Yeah, yeah,
like
yeah.
that, just passive
But in
douching.
these cases, aggressive douching can be counterproductive.
Yeah, that can be
But
controlled.
saline sprays we can use.
Yes.
Yeah, I think we follow the same. Okay. What else is there? When to start mobilizing the patient?
Ma'am, after pack removal, I remove the pack on day 5, and day 6, I ask them to, be for one day just that on bed, and after that
Yeah.
they can start going to washroom and all. But the
Yeah,
most
we just have
importantly,
to avoid like maybe lifting weights and
yeah, they have
straining.
to.
And
Yeah,
yeah,
that has to
yeah.
be there, ma'am.
Okay. Then another doctor has asked, in case of large encephalocele, is it advisable to cauterize and respect a part of the herniated meninges and brain?
No, ma'am, nothing which has come into nose should go back. So we
Okay.
directly attack the neck.
Yeah,
We don't
yeah.
deal with the herniated part. We reached up to the neck and we directly attack the neck. We never put any part which is herniated back into the brain because that is already non-functional. There is no point in keeping it back.
So we can cauterize and
Yeah, we
yeah,
can control.
like we can use the coblation and we can cauterize,
Yes,
but
yes,
definitely we are not going to put anything back. Yeah.
yes, ma'am.
Okay. Dose of cabergoline, Dr. Amit has already said that since it is advised for prolactinoma and infrequently dosed drug, infrequently used drug by the ENT people. So I think one has to check the dose and duration. Okay, how many days to keep the Foley's catheter? It has to be removed in the post-operative period. Mannitol dose during intraop.
Mannitol dose during intraop. Ma'am, that usually anesthetists they manage.
Yeah, we
So I
will.
am not actually sorry, but
Yeah.
I don't remember the dose exactly. The anesthetists they give, uh, I, do, I don't remember the dose. Sorry.
Yeah. And one question was about the drilling part, the size of burr. I think
Yeah,
the
that's
size of
important,
the
ma'am.
defect and the access to the defect would uh, make it that what size burr that we use.
Exactly,
Yeah.
ma'am. But the most importantly, the we don't need to drill in the cribriform area. The drilling is
Yeah.
required for lateral rectus sphenoid, the Stenberg canal things to
Yeah.
for transpterygoid approaches mostly. In that area, if we need to drill, then 4 mm either diamond or coarse diamond burr. The coarse diamond burr is good. It cuts faster with safety. So 4 mm the burr is usually which I use in the for transpterygoid approach. That's safe. But in
Yes.
anterior area, you don't need any drill. The bone is already very thin there.
Yeah. Yeah. Okay. And how frequently we need to follow up a case of CSF repair in the post-operative period?
Then post-operatively, we call them after a couple of weeks for endoscopy, and then we, as and when required, maybe 2 weeks in the initial till the crusting that disappears and the nucleation occurs. And in normally 6 weeks times, after 6 weeks, they might not require to come back.
Yeah, so it is not very different from a FES follow-up. Yeah, but depending upon the symptomatology and the etiology,
Yes, ma'am.
so you would follow up the patient. Yeah.
Right, ma'am.
So I think those are the questions. Any role of neosporin or antibiotic
No,
after
ma'am. We
nasal
just
pack
use this
removal?
Merocell that works fine, ma'am. We just impregnate the Merocell outer surface with some ointment, and
So
that
after
works.
removal of the merucil, do you put any antibiotic or neosporin ointment inside the nasal cavity?
No, no, ma'am.
No. Yeah.
No.
I think these are all the questions. I think you can check your chat uh, once more, but I think these are the questions.
Yes, ma'am.
Yeah, and the reverse Hadad flap, if you can.
Ma'am, reverse Hadad flap in cases of the septal spur, sometimes it is used. I have not used it in any of the case. I did not require, but that you have to elevate. It's and sometimes some people they use the entirely based flaps also, the same thing. But mostly the conventional Hadad is that's what we practice. In case of sharp septal spur, where you are not able to reach that area, then you can start it from the anterior side.
Yeah. Yeah, so I think Mr. Navneet, we can close the session.
Yes, thank you very much, Professor Dr. Amit Goyal, for the presentation, and thank you very much, Professor Dr. Nilima Gupta, for joining, and thank you, trainees and faculty members, for joining.
So, Dr.
Thank you.
Amit, thank you once again. And I think the notice was also short. Thank you so much for
Thank you, ma'am. Thanks a lot.
accommodating at a short notice. And it was quite an interactive session. Uh, we welcome you for more presentations.
Oh, sure, ma'am. I'll be happy.
Yeah.
Thank you,
Okay.
ma'am.
Okay.
Thank you.
Thank you.